everyone, my name is Marina and I'm one of the second-year residents in the internal medicine residency program, and today I'm going to be talking about the inpatient management of diabetes mellitus, and I also want to thank Dr. Silvio Nzuki, for helping me with this PowerPoint presentation. So first, just a brief outline of the topics I'm going to cover in today's presentation, which should be about roughly 15 to 20 minutes and serve as an introduction to the management of diabetes in the hospital. We'll review some basic principles and some need-to-knows about the management of diabetes. We'll go through the various types of insulin. We'll then talk about the Basal-Bolus-Correction method, which is how we actually do the calculations for the prescription of insulin in the hospital. And finally, we'll go through some sample calculations several times so we all get the hang of what's going on. All right, starting with the basic principles, really what we just want to do is to avoid the extremes. So avoid hypoglycemia and avoid hyperglycemia and keep the patient within a particular blood glucose range, which I'll talk about later. The reason we want to avoid hypoglycemia is probably pretty obvious. It can lead to seizures at really low levels and can lead to delirium and fluctuations in cognition, especially in the elderly patients. And with hyperglycemia, that's been linked to longer hospital stay, higher cost of stay, and then also poor wound healing and increase in infectious complications while patients are in the hospital. So really we want to avoid both extremes. And with that being said, we do want to treat hyperglycemia when the blood glucose is persistently above 140, even in patients that were not diabetic prior to their admission. And what we typically do is we discontinue their home anti-hyperglycemic agents. So if patients are on metformin or Januvia or anything oral, we usually discontinue those and just provide them with an insulin-based regimen in the hospital, whether or not they will ultimately go back on their home antihyperglycemics. And that's typically done because insulin itself is just easier to titrate while they're in the hospital and has more predictable effects. So it's just easier for us to control and to get them to within a particular target range that we want with insulin rather than their home antihyperglycemics. So it provides better control of their blood sugar while they're in the hospital. So what else do I need to know before I actually put in the insulin prescription for a patient? It'd be nice to know what their control of their diabetes was before they came into the hospital. So if they haven't had an A1C in the past few months, you can just go ahead and order that, and that'll give you a sense of how well their blood sugar has been controlled for the prior 3 months. And the reason this is important is because if their A1C was 7 or at target, for example, we know we probably don't need to make any adjustments to their regimen when they leave the hospital. But if their A1C is 14, for example, we know that probably we will need to either increase their insulin or put them on insulin or make some adjustments to their regimen so that they can have better control when they leave the hospital as well. We also want to know whether they're a type 1 diabetic or a type 2 diabetic, and that's important because type 1 diabetics, as you may know already, need insulin at all times, even when they're NPO or fasting or their dietary changes, whereas type 2 diabetics can get away with not having insulin usually. So that's important to know as well, whether they're type 1 or type 2. And finally, it's also important to know what their nutritional status is. Are they going to be NPO at midnight for a particular procedure? Are they on a consistent carbohydrate diet, which is the diet we typically use for diabetics? Are they on a regular diet? Are they on tube feeds? Because that influences how much insulin we give them and what specific type of insulin we're going to order for them. All right, so now that we went over some basic principles and some need-to-knows, I just want to briefly review a normal physiologic insulin levels and what we're hoping to achieve with good glucose control in the hospital. So the gray bars here, as you can see, are the normal physiologic insulin level. And as you can see here, there's always some physiologic insulin production in patients that are non-diabetic. And the reason for this is really to control the blood sugar in between meals, so here, and then also to make sure that we have normal blood sugar control at bedtime or while we're sleeping, and to suppress hepatic gluconeogenesis overnight, so here. So there's always some level of insulin production in normal patients. So we want to simulate that when we're prescribing insulin for patients in the hospital as well. And then you can see there are prandial spikes in the insulin production. So with breakfast, lunch, dinner, any meal or any carbohydrate load really. So if they have a snack in between, that would also cause their insulin production to rise. And so we want to simulate that as well. And the two ways that we're going to use, the two different ways that we're going to simulate the insulin production is with a basal or a long-acting, which is this green here, and then with the rapid-acting insulin analog to simulate this. Okay. All right, so now that we've reviewed our goals for insulin production in the hospital, I just want to briefly review the activity profiles of the different types of insulin and when we typically use each of those types. So the first one I want to talk about is the insulin lispro, aspart, or glulisine. Those are all different names for a very rapid-acting insulin. You may also see the names Novolog or Humalog. These are all the same type, so with various names for each of them. And as you can see, this insulin is a quick on and quick off. And this is the type of insulin that we typically use with meals. So it simulates the rapid onset of insulin production with a meal, with a carbohydrate load, and a rapid off. So typically this insulin is prescribed 3 times a day with meals. The second type of insulin that you see here is regular insulin. The effect of this insulin takes a few hours to have its peak effect, and it takes a few hours to go away. So it's a little bit longer acting than the very short acting insulin lispro that we talked about earlier. And typically this is dosed 4 times per day. And often this is helpful when patients are NPO and they don't have prandial blood sugar spikes because they're not eating. The next type of insulin that we can review is NPH. As you can see, this also takes a few hours to have an effect, but the effect lasts longer than regular insulin. And this is a type of insulin that's typically dosed twice per day, and it's an intermediate acting insulin. And then finally, the last type of insulin that I want to talk about is insulin glargine or Lantus. Those are both the same name for the insulin. And as you can see here, there's not really a peak. This is the dark blue line that we're looking at here. So the effect itself lasts for roughly 24 hours, as you can see here. So this is a long-acting insulin. It's typically dosed daily, and we typically use this type of insulin to simulate our endogenous insulin production over 24 hours. Okay, and this is just a diagram or a chart of the various insulin types for your own reference for the rapid-acting, the short-acting, intermediate, and long-acting here that we just talked about. And then it gives you the onset, the peak, and the duration. So this is a nice chart just to have for your reference. So finally, how do I actually manage my patient with diabetes in the hospital with all of that information that we just talked about in mind and the review of the physiologic or endogenous insulin production? And before we do that, I just want to briefly review our goals. So our typical goal blood glucose for patients is roughly 140 to 180. And the optimal targets are controversial. Really, as we talked about earlier, we just want to avoid extremes. So avoid hypoglycemia and avoid hyperglycemia. And the typical target that we use is roughly 140 to 180, as you can see here. And it's similar for the non-critically ill and the critically ill, though there are some nuances that you can see here. And we also want to avoid hypoglycemia because often that can have more dangerous consequences or side effects than hyperglycemia. And that's defined as a blood sugar less than 70. All right, so let's move on to the Basal-Bolus-Correction method. And this is how we actually prescribe insulin in the hospital and how we do our calculations for how much insulin a patient needs, both the long-acting insulin and the short-acting insulin. So the basal is a long-acting insulin. We can either give Lantus, which is dosed daily because the effect lasts for roughly 24 hours, or NPH, which is typically dosed twice a day. And this is supposed to simulate our own endogenous insulin production over 24 hours. The purpose of this is to keep your blood sugar within a normal range in between meals and at night. And then we also have bolus insulin. This is a short-acting insulin that's given with meals, and the purpose of this is to correct for post-meal hyperglycemia. So if I were to take in a carb load, my blood sugar will go up and my insulin production will go up to try to keep my blood sugar within the normal range. And the purpose of this bolus is to simulate that endogenous insulin production that would typically occur with a carbohydrate load with meals. And finally, there's a correction scale. The correction is also a short-acting insulin that's given with meals, and the purpose of this is to correct for pre-meal hyperglycemia. So for example, if I'm about to eat lunch and I prick my sugar and it's 300, as an example, I'd want to correct for the fact that my blood sugar is high even before I ate the meal, in addition to giving myself a bolus to correct for my post-meal hyperglycemia. So typically what we do is we add our bolus and our correction together into one injection. So for example, if I had calculated that my bolus was 5 units and my correction was 2 units, I would give the patient 7 units at once with the meal because it's the same type of insulin and it's given at the same time. And the correction scale, the correction is based on a sliding scale itself, either low, medium, or high, based on the insulin sensitivity of the patient. So let's quickly review that. This is an example of a typical correction or sliding scale insulin that we use 3 times a day with meals. As you can see, if we prick our patient's sugar before the meal and it's less than 150, typically we don't give them any insulin because that's within the range that we would already like, and we don't need to correct for any pre-meal hyperglycemia because it doesn't exist. Then, the number of units that we actually give the patient of insulin depends on their insulin sensitivity. So this would be a low dose, then this would be a high dose, and this would be a medium dose insulin. Patients that are highly insulin sensitive don't need as much insulin to have the same effect, and those would typically be type 1 diabetics or really thin patients. Patients that are highly insulin resistant need more insulin to have the same effect on their blood sugar, and those are patients that are typically obese, type 2 diabetics, patients on steroids, etc. And typically what we do is for every 50 of their blood sugar above 150, we give them a particular correction based on their sliding scale, as you can see here. All right, so how much insulin do I actually order for my patient? If they're not insulin naive and they're already coming to you on an insulin regimen, it's a good starting point. Now, it's important to keep in mind what their blood sugar control is before the hospital. So if they're on insulin when they come to you, but their A1C is still very high, you might need to increase the amount of insulin you give them to maintain their blood sugar within the 140 to 180 range that we talked about earlier. But regardless, it's a good starting point. However, if they're insulin naive and not coming to you on insulin, there's a specific total daily dose calculator that we typically use to make our own calculations of how much insulin we actually order for the patient. Typically, we use a total daily dose of 0.3 to 0.6 units per kilogram per day. Half of this total daily dose is given as basal or long-acting insulin, and half is given as bolus or short-acting insulin. So this total daily dose is all types of insulin combined. And if you ask an endocrinologist, often they'll typically start at 0.5 units per kilogram per day as a good starting point. So 0.25 of the basal and 0.25 of the bolus, total of 0.5 units per kilogram per day. And this is a chart that you can use to help determine a total daily dose for an insulin-naive patient. As you can see, the lower total daily doses are for patients that are more insulin sensitive and don't need the same amount of insulin to have an effect. So underweight, older age, patients on dialysis, etc. And you can use a higher dose for patients that are obese, very insulin resistant, or patients on steroids. But typically, the 0.5 units per kilogram per day is a good starting point, as I mentioned earlier. All right, so let's go through a sample order for subcutaneous insulin in a hospitalized patient. And our sample patient here is somebody who weighs 80 kilograms with a BMI of 28 and has normal renal function. So let's use the 0.5 units per kilogram of body weight per day. So 0.5 units per kilogram, as you can see here in step 1, to calculate our total daily dose, 0.5 times 80 kilos is 40 units, okay? And this 40 units is going to be given half as a basal and half as a bolus, which are step 2 and step 3 that you see here. So to calculate their basal insulin, you would do 50% of their total daily dose, so half of 40 units is 20 units. As you can see here, this is usually given as a once-a-day injection of glargine because that effect lasts for 24 hours, and then glargine and Lantus are the same type of insulin. So either 20 units one time a day of Lantus or Glargine, or you can use 10 units twice a day of NPH. That effect is the same. And then finally in step 3, we can calculate their bolus insulin dose. So half of the total daily dose is going to be given as a bolus, and that's spread out between the 3 meals. So half of the 40 units is 20 units here. And that's going to be given over 3 different meals. So 20 divided by 3 is about 6.3, or we should say 6 units of rapid-acting insulin before each meal. And then as you can see here in the text, how much insulin you actually end up giving with the meal depends on whether or not the patient eats. So if we remind ourselves the purpose of the bolus insulin is to correct for post-meal hyperglycemia, and that assumes that the patient actually eats the meal and thus has a carbohydrate load. If the patient doesn't eat their meal, there's no need for you to give them bolus insulin because they're not expected to have post-meal hyperglycemia if they're not eating a meal. Or, for example, if the nurse estimates that the patient only eats half of the food, on the tray you can give them half of the amount of insulin you had calculated for them. So that for this example, it would be 3 units instead of 6 units. And you can sort of adjust the actual amount of bolus insulin that you give the patient based on how much of the meal they actually ate. And then in step 4, we have the correction scale estimation. So this, if you remember, corrects for the pre-meal hyperglycemia based on a sliding scale, and that sliding scale is based on the insulin sensitivity of the patient. So if I'm about to eat dinner and I prick my finger and the blood sugar is above 150, which is typically where we start correcting, I know I'm going to give myself a certain number of insulin to correct for the pre-meal hyperglycemia in addition to the post-meal hyperglycemia. And then we will add the bolus insulin and the correctional insulin together and give that as a single injection with the meal, with each meal. Okay, let's go through another example so these calculations start to stick in our head. The second patient that we have is an 80-year-old male. He has type 1 diabetes, so on the insulin sensitive side, and he weighs 60 kilos. All right, so our step 1 is to calculate the total daily dose. And let's use the lower end, so 0.3 units per kilogram per day because he's older, he has type 1 diabetes, so he's pretty insulin sensitive, and he weighs 60 kilos. So 0.3 units per kilogram per day times 60 kilo is 18 units a day. And that's total types of insulin, both the bolus and the basal. The second step is to calculate the long-acting, or the basal insulin. So half of the total daily dose, half of 18 is 9 units. So you can either give 9 units of insulin Lantus or Glargine a day, or you can give 4 to 5 units twice a day of NPH. Step 3 is to calculate the short-acting, or the bolus insulin. So half of your total daily dose divided by 3 is how much you give of Lispro, or the rapid-acting insulin, per meal. So 50% of 18 is 9, divided by 3 is 3. So you calculate that out to be 3 units of the short-acting insulin, or typically what we would give is insulin Lispro per meal. And then we would have a correction based on the sliding scale, and we would add that to the bolus insulin that we had calculated previously to give the total number of short-acting insulin with each meal. All right, so now let's go through some sample adjustments. So say we had already done our total daily dose calculations, and we had decided that we're going to give a patient 12 units of Lantus nightly, and then 2 units of Lispro 3 times a day with meals, plus a low-dose sliding scale. So we put in those orders, the patient gets the Lantus, gets the Lispro as they're prescribed, and then what do we do if their blood sugar is still high, despite these calculations that we made? So let's go through some samples, or examples, I should say. Our example 1 is, say you gave the patient 12 units of Lantus the night prior, the patient sleeps, they wake up the next morning and their fasting, or AM blood sugar, is 246. Now you noted that this is higher than the 140 to 180 range that we typically like, so we want to correct for this and increase the insulin that we gave the patient because we didn't give them enough because their blood sugar is still too high. Typically what we do is we use the fasting or the AM blood sugar as representative of the long-acting insulin that we gave the patient. So the fact that the blood sugar of 246 is still too high is reflective of the Lantus, or the long-acting dose that we gave the patient. So what I would do is increase the basal insulin. So as an example, in this patient, I would maybe go up to 15 units a night for that night, and then recheck the next morning's AM blood sugar and correct accordingly. All right, so for our example number 2, say our pre-lunch blood sugar is 300. Again, this is above the typical 140 to 180 range that we would like the patient to be in, and it's above 150, which is where we typically start correcting for their pre-meal blood sugar. So what would I do? Number 1, I would give them a certain amount of bolus or correctional scale insulin based on pre-meal hyperglycemia, based on the correctional scale that we went over a few slides previously. And then in addition, the fact that their pre-lunch blood sugar is high is reflective of their breakfast insulin. So you can use the pre-lunch blood sugar to see whether or not the amount of insulin you calculated for breakfast was appropriate. You can use the pre-dinner blood sugar to see whether or not the pre-lunch, the lunchtime insulin was appropriate, and you can use the bedtime blood sugar to see whether or not the amount of insulin you gave for dinner was appropriate. So the fact that the pre-lunch blood sugar was high is partly reflective of the fact that we may not have given the patient enough insulin with their breakfast. So that was kind of a long-winded answer, but what I would say is I would give them the correctional Lispro or the rapid-acting insulin with the lunch per the sliding scale, and then I would also increase the breakfast Lispro in the hopes that the following day the pre-lunch blood sugar would be lower. All right, let's go through another sample. Say your pre-bedtime blood sugar is 160. So that's actually within the range that we would typically like it. So what I would do then is the pre-bedtime blood sugar is reflective of how much insulin you gave, that whether or not the insulin that you gave with dinner was appropriate. So then what I would do is I would give them the correctional Lispro with dinner because their blood sugar is above 150, but I wouldn't adjust their dinner time Lispro because the amount of Lispro that you gave the patient with dinner was clearly appropriate because their pre-bedtime blood sugar was within the range they would like it to be. Now, I know some of these examples can be a little bit confusing. They require a good understanding of the basal, the bolus, and the correction. So if you have any questions about any of these examples, you can feel free to email me with my email at the end of this presentation. And then finally, I just want to make everyone aware that EPIC actually has order sets for this basal-bolus correction method that we talked about and did some sample calculations for. So there's no need to actually remember the total daily dose units per kilogram per day that I talked about because it's already built into EPIC. So as an example here, if you go into the order sets and you type in basal-bolus correction, click on it, this will pop up, and it'll actually walk you through the basal dosing for first-time users and how many units per kilogram per day you should use and what type of orders you should put in if you plan to use the Glargine or Lantus or the NPH. So it kind of walks you through. Same thing with the mealtime bolus, which as I mentioned earlier, use only if the patient is eating, because if they're not eating, they don't need to correct for post-meal hyperglycemia. And they walk you through how many units per kilogram with each meal. So 0.05 with each meal will be about a total of 0.15 altogether. And then the correction dosing also. So you have a low dose, a medium dose, and a high dose, and also custom dose if you need it. So these are very helpful when you actually put in orders in the hospital for these patients. All right, and that's the conclusion of my presentation. I hope that was helpful and provided just a good basic overview of the management of diabetes in the hospital, though of course there's a lot of nuances and various patient scenarios. So if you have any questions at all about either this presentation or any follow-up questions for the presentation or more specific questions, you're always welcome to email me. My email is marina.mutter@yale.edu, and I will be very, very happy to answer any questions that you may have. And thank you to Dr. Nzuki for assistance with this presentation.